much for joining us tonight and for this webinar about how we can make our lives easier with restorative dentistry and make things last longer. Now, if you do soft tissue surgery all the time, then it will be obvious how it can make your life easier. But if you don't, or you don't do it at all, then it might seem a little bit confusing as to why a procedure that seems complicated makes your life easier. And that's because sometimes we mistake what makes things easy for us and what makes things cheaper for the patient. They're not always the same thing. An example might be if you do a very deep subgingival restoration, that can be exceedingly difficult for you. But if you do crown lengthening, then it becomes quite easy. From the patient's point of view, though, it becomes more expensive, or maybe there's more procedures involved. So we need to be very clear that I'm talking about what makes life easier and more predictable for you, not necessarily easier and cheaper for the patient. Now, normally a soft tissue lecture starts like this with a big list, and then we go through the classifications, and then we tell you the whole history from the first person to publish it, and we do indications and by this time you're starting to get a little bit sleepy. And then of course I finish with the most complicated and difficult graph that I ever did, and it's a miracle that it actually worked, and then I pretend that I do these all the time, and that's not what we're going to do at all tonight. So tonight I really want to focus on why it's a good idea to not think of this as some special procedure that you do occasionally, but why you put it in every day, whether you do the procedure or whether you refer the procedure. To get away from this mindset of types of graphs, of classifications, of millers, of things that are very mathematical and maybe a little bit dull, I want you to think about what is your problem. Now that could be you as a dentist or the patient. So what is the problem that you need solving? And then how can we solve it? And I really want you to think about soft tissues as part of restorative dentistry. It's not restorative dentistry and then there's gum bits that there's some mysterious. It's part of restoring the dentition, because the dentition is not just the white bit that pokes out of the gums, it's also the gingiva. So we're restorative dentists, we try to restore or rebuild or replace. And so part of that job is to restore the soft tissues. So let's start to think about some of the problems that we have as restorative dentists. And one is predictability. Now, this is a crown that I did just recently, and it was done with a vertical preparation. Now, vertical preparations in general are something that we suggest causes better soft tissue. It causes the less likelihood of the tissue receding and all this sort of thing. Unfortunately, this patient's tissue didn't listen to what was supposed to happen, and we've had recession. And we've had recession straight by the time the crown has come back from the lab. So within 4 weeks, we've had recession. Now, on this particular patient, he's nearly 80. It's his upper first molar. You can't see it without retractors in a mirror. So it's not really a catastrophe. But we know that when we do front teeth, it can be, or it can be risky. Some things aren't necessary. A recession on a new crown is not necessarily a catastrophe, but it can be risky, because we don't know whether the patient will be annoyed by it or not. And if they are, then it's a difficult conversation. And in this particular case, what happened, I took the impression several times, and so I had retraction cord with Viscostat Clear. So I had something in there that was irritating the gingiva, and then by the time the patient had come back, quite often when you use these things like Viscostat Clear, you can get a chemical burn of the tissue if you leave it in for too long, and then you get recession. So this of course happens because the tissue is thin. So one of the things that we want to do is make restorative procedures more predictable. And I'll come back and talk about this a little bit more in a moment. But how do we do something so that we know that we won't get recession? Not just hope, but we know that we won't get recession. And how do we not end up fighting with blood, with retraction cord that you poke in here and then it pops out there, and things that get very time consuming, very frustrating. So predictable restorative is one of the things we want to solve. Another one is things like this. These implants are ones I did about 8 years ago. 8 years ago, we didn't really think about soft tissue as much as we do now when we place implants. And it would be a similar thing if you look at some of my old cases where I've done crowns on patients with very, very thin gum tissue who brush very hard or whatever the reason for their recessions. And they have these lovely cases, but they've got 3 or 4 millimeters of recession. And so that doesn't always affect the longevity of crowns on teeth, except that we end up doing a new procedure because they don't look nice. But on implants, it definitely can. It starts to get quite difficult to keep these implants clean because there's no tissue of any strength there. The tissue is flimsy, it's moving. Every time the patient moves her cheek, the tissue is lifting off the implants. And what we tend to notice is the patients get sensitivity. They get sensitivity to the tissue because the tissue is too thin to brush, to floss, or to use any sort of interdental brush. So there's another part of our restorative. We want to be able to put crowns on implants and teeth and not have wear, not have recession, not have things risk where the crown or the restorative work is perfectly good, but it has to be replaced or redone just because of the soft tissues. So there's our second thing, that we want to have longer lasting treatments. And longer lasting treatments start with the foundation, not just whatever the restorative material is. Of course, we have aesthetic issues. So now the reason why I'm thinking about the goals is because the way you approach soft tissue grafting should be entirely driven by whatever you're trying to achieve. So in this particular case, the patient's main concern is the way it looks. If her only concern was to stop it getting worse, then the type of treatment I might do might be quite different. And it might be a little bit dependent on her age, but certainly one of our goals that we're trying to solve with our soft tissue surgery or with any sort of soft tissue management is to improve the aesthetics of the teeth. So far we've looked at things like predictability, longevity, aesthetics, but sometimes we're really looking at prevention. So something I have seen in quite a few people is particularly females who have really, really thin alveolus. So there's no buccal bone on their teeth and there's no lingual bone on their teeth. The only bone holding their lower incisors is the interdental bone. And you can see that you look down on their alveolus and it's so slim, you can see the bulge of the roots on the lingual and the buccal. And they have a frenal pull and it's difficult to clean, and so they end up with this type of recession very early in life. So this patient is only in her early 20s and she has a recession like this. And what I see is that they're not treated, and when they're 40, these patients sometimes lose a lower incisor or sometimes 2. And it's devastating for them. And any other type of dentistry, we would do something early to stop it getting to that stage. So we might suggest to a patient, let's restore this small cavity so that you don't end up needing a root canal therapy or an extraction. And so why not take the same approach when we see something like this? This is a very risky defect for someone to have at such a young age, and she can't keep it clean, even though she's very intelligent, she's a healthcare professional. Oral hygiene everywhere else is fantastic, but she can't clean this area because it is too tender. And essentially she's at risk, with a perfectly healthy mouth, everything is beautiful, of losing this one tooth in the future because of recession. So sometimes we need to take a preventive approach, and soft tissue surgery can be part of that. And then of course we can think about lost tissue as well, which is, if we go back to this case here, we can also think about the lost tissue, which is the patient who has lost tissue and for whatever reason we want to bring the tissue back. So they're the main things I want you to think about with the soft tissues. How can we be predictable? How can we get better longevity, better looking things, how can we prevent loss of teeth, and how can we deal with lost tissue. So now, when we look at all those things, what we want to then consider is size and difficulty. The size and the difficulty will influence a lot how you approach these cases. And of course, the patient will also. And of course, one of the things that really holds people back when they're looking at this process, so they kind of know the goal, that bit's easy, and then they start thinking about how big the procedure is and how difficult it might be. But then they reach a blockage, and the blockage is they start thinking about the patient and how much it will hurt. Now, so the question is, and this is the bit that will hold more people back than the procedure or anything else, is will it hurt? Will it hurt the patient? Will it be very painful? Now you see, if you're afraid of it, then the patient will be afraid of it also. And mostly when I hear people say, oh, the patients won't go ahead with this procedure, what they're actually meaning is that I'm afraid. As a dentist, I'm afraid of the procedure. And I'm going to give you a few little things to help you think about this in a different way. When you do a soft tissue graft, the biggest soft tissue graft I've ever done was where I've harvested from the palate, was about 4 millimeters wide, and it went all the way from the central incisor all the way around the palate and around the back of the tuberosity. So it was probably about 45 millimeters long. So 4 millimeters by 45 millimeters. Okay, now when you're a dentist, that sounds horrific. That sounds like a massive wound. And so I just want to give you some things to put that in perspective. This is a knee replacement. This is a genuinely painful recovery. That wound is a lot bigger than what we're talking about, and this person has had the whole top of their knee cut off and holes drilled in the top and a plate put there. Okay, and then they've had one done on the other knee, and then they get a little bit put in between. This will hurt for several weeks, maybe months. Foot surgeries can hurt for 6 months. A hip replacement often hurts for 3 months after the surgery. Okay, and it's incredibly painful for the first week afterwards. This is open heart surgery, and it's probably the most painful type of surgery you can get. Having your sternum cut is properly horrific and jacked open. Okay, so now next time you say to me, will it hurt? First of all, yes it will. Okay, if you have soft tissue surgery, it's going to hurt. Okay, but get over it, you're a surgeon. You're talking about something that's like 12 square millimeters. This is what surgeons do. They cut the chest in half and jack it open. Yes, it will hurt, get over it. You're the surgeon, it won't hurt you, it will hurt the patient. They'll get over it. And so patients often ask me, will it hurt? And I go, yes. Yes, it will. It will hurt for about 5 to 7 days, you'll get over it. If you say that, then the patient goes, okay, fine, I'll cope with that. But you go, oh, no, we totally won't hurt, might hurt a little bit. You make such a big deal about it. It's kind of like when the parent brings the child to the dentist and on the way to the dentist go, oh, don't worry, it won't hurt. And you would go, why would you say that? That's right, I'll drop the clicker, I'll get it myself. You would say, why would I say that? You don't go to McDonald's and say it won't hurt, okay? I don't go to the movies and say it won't hurt. So yes, it will hurt, it's fine, okay? You're a surgeon, you're supposed to cause people pain, give them drugs, not recreational drugs, okay, like ones that you prescribe. So do what you have to do, but get over the fear. That's the single biggest thing that will hold you back. Now, this particular presentation is not really about teaching how to do this. If you want to learn more about soft tissue surgery, you can go onto the academy. There's a whole bunch of, you can join for free. There's a whole bunch of videos there on how to do these procedures. There's really, really intense lectures there and so on. But just 2 basic factors if you're prescribing this procedure. So if you don't do soft tissue surgery yourself and you're referring it out, just a couple things so you don't sound kind of completely lacking in knowledge when you refer out. Firstly, if it's massive, you're probably going to use an allograft, which is tissue from the same species as yourself from another human, but not from the human you're currently treating. Now, obviously when I learned to use allografts, I went crazy and I used them everywhere. This is normal when you learn a new procedure. However, for me, there is a very specific indication for it, and that is cases that are not horrendously difficult, but are huge. So this particular patient, we did I think a 23 tooth soft tissue graft. Now you cannot take enough tissue from the palate. If you took the entire palate, you would not have enough tissue to graft this many teeth. Okay, perhaps if you're feeling adventurous, you could harvest the hairless skin from under the arm, but that's generally not considered something that dentists should do. So I would suggest maybe if it's a really massive one. And sometimes I will accept a poorer result for the fact that I can put the patient to sleep under general anaesthetic and do all of their teeth at once. As the difficulty increases, I definitely want to use tissue from the patient. So that's my balance. My balance is big versus difficult. If it's really difficult, then I'm going to use the patient's tissue. If it's really big, I'm going to use artificial tissue. So let's go through these things of why we want to consider soft tissue and how it can make our life easier. Let's take a case like this. Now, this patient came in with pain because she has a 4mm pocket on that mesial root. This tooth is incredibly important to her. She has medications which make it a little bit difficult for her to have implants. She doesn't have really very much bone around this tooth, so it'll be very difficult to do implants. She's in her mid to late 80s. This is the terminal abutment that holds her denture, and without it, her denture will rock. So this is a really important tooth, but think about taking an impression on a tooth like this. If you do a crown on this tooth, oh, by the way, the tooth is broken as well, so it's got a crack on the side of it. It needs to have a crown. It needs to be restored. So if you try and work on this particular tooth as it is, you are going to have a massively frustrating appointment, because what will happen is, first of all, you will push the retraction cord down in that mesial root and it will disappear 4mm down under the tissue. Okay, and you will get no retraction at all. So when you take the impression, there will be no sulcus for you to capture the margin of the crown prep. You could put 4 cords down there before you'll have lifted the cords up to a point where it will actually retract. So that's happening, and then as the cord goes around into the furcation area there, you'll push the cord into the furcation and it will lift back out off the mesial root. And then you'll push it down on the mesial root, and where it is in the furcation, you go hello, and it'll pop back out, okay? And this will go on until you feel depressed. Okay, and most countries in the world you shouldn't start drinking in the middle of a procedure, and this is a high risk for that happening type of procedure. So you can see immediately this is a nightmare. You might not see it as a nightmare, but if you book this case for the same amount of time, it will be a nightmare for you. So in this particular case, we've done a big graft there, and you can see now when I probe that mesial root, there used to be a 4mm probe depth if I go back. So we had 2 or 3 millimeters of recession, and we had a 4mm probing depth. Now you can see after the surgery has been done, first of all, the tissue is perfectly healthy. There's no bleeding, nothing. And we can see that I can probe as hard as I like on that mesial root, and okay, maybe as hard as I like is an exaggeration. I'm sure that I can surgically probe this mesial root if I wish to, but I'm probing hard enough to cause blanching of the tissue there, and you can see the probe is only going 1mm. I can place cord here, and the cord is easily going into the tissue and staying there. From a restorative point of view, now that the surgery's been done, the crown prep is easy. It's really easy. There's no bleeding. The cord goes into the sulcus and stays there. When you have nice thick tissue, you can actually retract the tissue without causing trauma, so it doesn't bleed. I don't have the problem of the cord disappearing into the furcation and then it pops back out again. I'm not trying to record an impression, so it's more accurate, it's less stress, the prep is easier, everything is easier. And you can see how nicely that tissue looks around the crown as it's gone in. And then a year later, because the patient can clean it, the patient can get in there with a brush and scrub as hard as they like, and it doesn't cause any inflammation, it doesn't cause any ulceration, it doesn't cause anything, sensitivity or any of this issue. So the patient can keep it clean, and you can see that by how clean the furcation area is. And the furcation area is one of the prime areas to break down on a crown like this. You do restorative work into the furcation, they're very, very easy. Crowns, fillings, anything, they very easily break down in this area and get secondary decay. So whilst the surgical procedure was a bit tricky, when I came to the restorative procedure, I've now made something that is predictable, it's easy, it's long lasting, after several years this case looks even better than it did at the time. You can see there's no furcation probable at all, so this was originally a class 2 furcation. I could get the probe in about 3mm into the furcation, and now there's no furcation at all. So a typical example of taking a procedure. Now, you might go, yes, but that's a very complex procedure. Yes, it is. But the surgery isn't so complex. It's complex because you may not be familiar with it. But the restorative, I know the restorative will work. So what you're in a sense doing, if you try and do this case without correcting the tissue, you've taken the patient's problem, which is they have bad tissue, and you've made it your problem. You're trying to cope with their bad tissue. And it's the same when we do a really subgingival crown prep. We're taking a patient problem, the patient has a really deep margin because of decay or because of fracture or whatever. That's a patient problem. But when you try and do this without correcting it, you're now making it your problem. So let's look at longevity. This patient actually came in and she had, her lower incisors were mobile. She wanted her teeth straightened. She had grade 2 mobility of the lower incisors, and she came in saying, look, I need to have these teeth extracted. I don't think that they will last any longer. And when I looked at them, I agreed with her initially. But what actually held us up, and thankfully it did, was it was actually to do implants at the time was too expensive for her. So we said, look, what we will do is we will improve your tissue, we will straighten your teeth, and we'll keep these teeth there for as long as we can, and when they eventually fail, then we will do implants. And what actually happened is we did a massive soft tissue graft. So this is one of those ones that goes from, when I harvest on the palate, it goes from behind the front teeth all the way down the side and around the tuberosities. You don't want to see the patient too soon for the post-operative review because they're very grumpy for a week. So sometimes it's better to go, I'll see you in 2 weeks' time. This is not at the time the graft was done. This picture is taken quite a few years. It's about 6 years post-operatively. So we did the graft first. This gave us stable tissue. It didn't give us a wide band of stable tissue, but it gave us a band of attached stable tissue, and she was able to clean a lot better, and the tissue was stable, so it wasn't prone to any further recession on her teeth. This allowed us to do orthodontics, even expansionary orthodontics. So a patient who already has recession, has lost interdental papillas, and we were able to expand her lower arch, place retaining wires, and have good healthy soft tissue. And 6 years later, her teeth look better than when we first treat them. So, I mean, on the downside, I don't get to do implants, and I'm not sure that I ever will with this patient. But from the upside of longevity, I'm very, very doubtful we could have maintained the health of these tissues as well without having some attachment and without having some thickness of tissue so that she could clean and so that the tissue was stable. Previously, if you look at the previous picture, you can see where I'm retracting her lip, the tissue is lifting up all the way to the tooth. So there's essentially no attached tissue at all. And if you ever do a crown prep on a lower premolar like this patient, you can actually cause a surgical emphysema. I've had the only surgical emphysema I've had from prepping has not been from an extraction, it's been from prepping the buccal of a lower premolar in a case like this, where there's no attached tissue. I placed a little bit of cord, stripped it, and as I started prepping the tooth, her cheek started inflating. Okay, I'm glad that I saw it very early and put her on antibiotics and so on, but could have been disastrous. And when you survey a room of dentists, most dentists will tell you that surgical emphysemas have happened during a crown prep on a lower premolar, not from sectioning teeth. Aesthetics. So sometimes, this particular patient came in because she was worried about losing her lower tooth, but she also didn't like her upper teeth, and that's because there is a lost lateral incisor, or is missing lateral incisor. So we have a canine there, and we're trying to make the canine look like a lateral. And this is very difficult. Apparently, patients don't really notice when their lateral incisors have a big neck on them, but dentists really do notice. So in the process of trying to disguise this, we wanted to bring the soft tissue down over the canine to disguise the gingival height that we see on canines. But I knew that I would not be able to bring the tissue down enough. So for aesthetic purposes, our soft tissue management was actually to bring the tissue down on that tooth and lift it up on everything else. So that's allowed us to go from the picture on the right to the one on the left, where we've really evened out the soft tissue profiles, even in a very difficult case. So very difficult when you have big bulbous canines with very high tissue, it's difficult to bring the tissue down enough, and I would never be able to bring it down enough to match the other teeth. So it's that combination of bringing tissue down and lifting tissue up to give us good aesthetics at the end. Now, without that, possibly the patient would be happy, but that's the problem with these sort of cases, is that you're never quite sure whether the patient will be happy, and it's something you need to discuss with the patient. Are you happy with your gums not being even? Now, I know that 10 years or 15 years ago, none of my patients cared about the gums, but now they do. So either I have fussier patients because I've become more fussy, or the general population is getting more knowledgeable about aesthetics, and I think it's a little bit of both. And things that you do early in your career that you may get away with because you tend to attract much less attention to detail type patients early on. Later on in your career, you'll never get away with it because as you become more well known for whatever it is that you do, your patients that are attracted to you become much more fussy. This is another case. You'll start to notice a lot of these cases are combinations of restorative, ortho, and periosurgery, and those three things together are always the holy trinity of really restorative dentistry. Unfortunately, those things all fight with each other. Orthodontics tends to, if anything, increase recession. So if you're going to get any effect from orthodontics, it's usually to increase recession. And orthodontics also makes the need for restorative dentistry greater in many cases because it exposes black triangles. So you can see that these three things are in tension. But in this particular case, you can see that it's impossible really to get good aesthetics here because her main issue is the height of the gum. She's concerned about the height of the gums. Now she's come in and said, look, I really want my teeth straight, but I'm concerned about my gums receding up, and when I smile, my teeth are getting longer and longer. So these two things. Now I know that if I don't treat that with the type of tissue that she has, the tissue that's thin with no attachment, she will get recession and I will make the problem worse. So to have a predictable orthodontic outcome, I need to have really solid, thick tissue that's stable. And to get a good restorative outcome on the crown that's got the dark margin, I need to have thick tissue that's brought down. And really, so all three need to go together. In a case like this, I'm going to get the tissue fixed first. This was the one I showed you earlier, and this patient was quite terrified of the procedure. She knew it needed to be done, and what you will find with these patients is that some of them are indeed quite scared, and you don't push them. So this patient has been in my practice for 18 years, and I think I first mentioned her recession about 9 years ago. She comes in for a checkup and go, I'll take some photos of the recession so I can track whether it's getting worse. And a lot of these patients are really a seed that you plant, and you will harvest that seed later on and it will grow into a tree. So this patient, probably 9 times I said, look, you've got some recession, it's getting worse. She says, I know, I don't want to deal with it. She comes back a bit later and she goes, I know, I don't want to deal with it. And finally I said, look, what are you worried about? She says, look, I just hate the idea of the procedure. I said, well, why don't we put you to sleep and we'll do it all at once. Now, of course, if I'm doing it all at once, I can't use the palate, so I have to use alloderm or an allograft of some sort because there's no way to do this number of teeth otherwise. You can see aesthetically it looks a lot better. At 3 months, we did orthodontics, and You can see right at the end of the treatment, 6 or 7 months later, that the aesthetic is far improved. It's not just improved because the heights of the tissue are correct, but it's improved because the tissue itself looks nicer. We like thick, healthy gums around teeth. Thin gums, they just don't look as nice. Even when they're not receded, they kind of look like they're about to. There's something about thin gums, and maybe it's just because the patient can't brush easily on thin gums or something like that. I'm not entirely sure, but the aesthetics of thick tissue is just always nicer. And you can see, obviously, she can also brush now. Previously, we often have patients have a little bit of trouble cleaning when the tissue is thin because it hurts. And they'll come in and they'll complain of sensitivity, but it's not sensitivity. They'll go, it hurts when I brush. And you can very easily think it's dentine sensitivity, but it's not. They're actually getting tissue trauma every time they brush. And in thin tissue, they'll tend not to brush, and then they'll get plaque. And then the plaque causes dentine sensitivity because of acid production. So you can get dentine sensitivity in these patients, but it's not always because of the wear of the tooth from the toothbrush. It's often because they don't clean it properly because the toothbrush hurts the tissue. From a prevention point of view, there's two types of prevention, and one I mentioned earlier was the patients who have stripping on their lower incisor and they are at risk of losing a tooth later, and it's usually in their early 40s if they're going to lose a tooth from that particular type of stripping. The other type of prevention is implants, preventing recession around implants, because recession around implants is disastrously, disgustingly ugly. So here's a case. This patient has fairly thick tissue, but when it comes to implants, my observation over many years is if it looks beautiful, it usually lasts well. And what I mean by that is to make an implant look beautiful, you need really thick tissue. If the tissue is not thick, it looks like an artificial tooth. But when you get an implant case to the point where it looks just like a natural tooth emerging from the tissue needs to be quite thick and robust. And so the things that make it look beautiful are also the things that make it long-lasting and prevent problems like recession. So this particular case, we've grafted the tissue. In the past, I would have just placed her implant, and she actually asked me, because I've done an implant on her left side way back when I first started doing implants, and it was my typical raise a tiny flap, squeeze the implant in, the bone's probably too thin, there's a good chance that it's resolved by now, and all the threads on the buckle of her implants are covered by soft tissue only, and very thin soft tissue, because when she smiles, I can see a very tiny grey line going up from her implant on the other side. Whereas this side, I'm quite confident that there will not be a grey line for maybe 10 or 20 years. Now, the patient said, why is it taking so much longer? Because the first implant I did took 3 months. That's placed the implant, and then I made the crown at 3 months. And the second implant, I had to do a bone graft, so it was a little bit more complex, but once the implant was placed, then we waited some time for the implant to integrate, and then we uncovered it and did a soft tissue graft, and then we waited some time, and then we started to shape the tissue. So it actually took about 9 months longer to do the second implant than the first one. So it was less convenient for the patient, that's for certain. But when you explain to the patient, okay, yes, I can do this, but in my experience over the last 10 years, the patients get recession and sometimes they get this thread showing. No patient wants to make compromises. Well, that's not true, there's always one patient. Most patients, if you explain what will go wrong if you don't do it, they are happy to do it. So patients will only do compromises when they think they will get the same result. So in her case, she goes, okay, the last implant wasn't very long, and I said, yes, but look, the tissue's already receding, and I can see a grey line, and I will probably need to soft tissue graft this implant anyway. Why not just do it right from the start, and it will look more beautiful, and it did. So mostly, if you are sincere and you truly believe in the benefit, then the patient will go through it, even though it's painful and it takes more procedures. And then obviously lost tissue. This patient had orthodontics. She had recession before the orthodontics. The recession got slightly worse during the orthodontics. And now, and this was a learning curve for me, because now if I had a patient like this, I would either explain to them at the start or before I started the orthodontics that they need a soft tissue graft, or I would even include it in the treatment plan. So I'll do orthodontics, and at the end you'll get a soft tissue graft if you need one. And that's because I find it much easier to tell the patient their treatment will be shorter and less expensive and less involved than they thought, than to tell them it will be longer. This is the case a few months after, it was about 3 months after the graft was done, and this is 3 years later. So in this is a case where we're able to bring the tissue back that has been lost. And she was only in her 20s, so this was not an old patient. But in her 20s, she's already got 3 millimeters of tissue loss and losing a papilla. We know that she will continue to lose tissue, very likely to continue to lose tissue and end up with the big recessions that are very difficult to fix. So that, now one of the things I will say is that the first graft I did was about 12 years ago, and soft tissue grafts are the only type of procedure that I do. Just excuse me, Jimmy, can you get this in water, please? Sorry, I just had a cold. Soft tissue grafts are the only procedure that I do which gets better with time. So when I do restorations, they... Thanks, Julian. I'll be back in a moment. Soft tissue grafts are the only thing I do which gets better. So when I do a composite resin restoration, they wear out. When I do a crown, they wear out. When I do root canal therapy, the tooth eventually splits. If I have a patient with a bite guard, the bite guard wears out, it cracks or it chips or something. Soft tissue grafts, in most of my patients, if they are a good result at the start, they get better and better and better. I had a patient recently, actually I might post it soon, patient who had a free gingival graft done 30 years ago, and it just looked absolutely amazing. It's like there's 2 areas of pristine tissue in her mouth, and then everywhere else it's thin and there's a recession. Now the key part is what is predictable and what is not. Predictable, there's many ways to know what's predictable, and theoretically it's really based on the bone, not on the soft tissue, but a rule of thumb that works very well for me is the 3 millimeter rule. If you look at this patient's concern is actually staining off his upper teeth. So we can improve the aesthetics of this patient's upper restorations by doing a soft tissue graft around those upper front teeth. Those upper front teeth, there is discoloration on the 1-1, which will show through the tissue as it is currently. And the patient had this crown done in the past and then the tissue receded. So this is an aesthetic issue. Just as a bonus, you can actually see where he cuts his tissue with the toothbrush every morning. So if you look at the papilla between the 1-1 and the 2-1, you can actually see the divot where he cuts it with his toothbrush. So aesthetically, we want to thicken the tissue enough to block out the colour of the root, and we can do that. Once you're getting up to 1.5 to 2 millimetres of tissue, in general, you won't be able to see the root through it. And more importantly, when you place the crown, you won't get recession within any short time frame. And often, well, I have cases where I've had no recession, big recessions that we repaired and placed a crown, and then there's been no recession for 10 years. In fact, the tissue is actually grown down over the edge of the crown slightly so that the crown looks better than when it was first done. So can I bring the tissue down over this recession on the upper tooth? You can bring tissue down predictably to within 3 millimetres of the tip of the papilla. So if you look where the papilla is between those front teeth and then measure 3 millimetres apical from there, that's about where you can bring tissue to on average. Now, you will sometimes get a miraculous case. So I've had cases which were miraculous. I was able to bring the tissue way down more than that, but in general, that's not predictable. That's something where we go, yee-hee. when it happens. So now the second part of the 3mm rule is that the base of the papilla must be 3mm wide. If you look at those lower teeth, you can see that there is no chance of bringing that tissue back to where it was, at least not for ordinary mortal surgeons. You see, when you look at those lower teeth, you can see that 3mm from the top of the papilla between the teeth is about 2mm down the recession defect. So even if I can bring the tissue up to within 3mm of the top of the papilla, I am still not going to be able to get it up more than maybe 2mm from the DJ. So that rule has stood me in good stead for treatment planning. So in a case like this, the patient actually came and said, look, I'm concerned about the recession. And I said, on your lower teeth, I can make it so it doesn't get worse, and I can cover the recession a little bit, but I will never get the tissue back. So I can know what I can and can't do based on that rule. And that's a good one to keep in mind just for daily practice. On the upper, I know that it will be difficult to bring the tissue down over that dark root. I can make what's under the tissue already disappear, so that I can make the shadow in the gum tissue disappear, but I probably can't bring that tissue down, so I'm going to have to replace both those crowns. So that's a really effective treatment planning tool that tells us what we can and we can't do, and then we can, sometimes we bring tissue down on one tooth and we'll lift it up on the others to get it even, because we know we will never bring the tissue down enough. And other times we know that we will have to do restorative work as well as the soft tissue surgery, because we can never bring the tissue down. Here's another case, and you can see here that there is recession on all the way across. This patient lost her lower incisors, but on the remaining teeth, you can see that there's recession on both the left and the right side. But you can see that the recession on the left side is much worse. And so when we look at that, we think, can we get the tissue up? Yes, on the right side, we can probably get the tissue all the way up to cover those recession defects completely. But on the left side, maybe not. So if we look at the left side more closely, you can see if you measure 3mm from the top of that papilla, it's going to be about halfway down the recession defect, and particularly on the mesial where that canine is. So you can see on the canine that the mesial papilla, if you've got two papillas and one of them is not as good as the other, you measure from the bad papilla, not the good one. So if you have one papilla down and one up, you're going to measure from the down papilla. So this one, you can see that papilla is down. We are not going to bring the tissue up any more than 3mm from that mesial papilla on the canine and from the distal papilla on the second premolar. So we don't expect full coverage here, and that's what we got. There are technical things I could have done to make this case more, I guess, get maybe some better coverage, but unfortunately the patient was extremely difficult and had to be treated because of her medical issues in a fairly short time frame under general anaesthetic, and so there were some limitations on the actual surgery. So that's the rule that I use for treatment planning. Now, if you want to get into more detail, then if you ever get a chance to listen to Michel Azza, any of his courses on basically how bone supports soft tissue are tremendous. I think there's one on the Academy, or there's one coming on the Academy soon. And but in general, for everyday practice, look at the 3mm rule. Now, how do we normally treatment plan these cases? Well, normally what we do is we go to a course, okay, and then we go all Oprah on everyone, okay? You get a soft tissue graft, and you get a soft tissue graft, and you get a soft tissue graft. And this is a normal thing that we do with almost any procedure that we learn. At the moment we learn it, we want to apply it to everyone. But that's not really a very good way to treat a plan. So I think a much better way is really to understand the goal, okay? Diagnose the case, and then work out how to treat it or refer it. It doesn't matter when you're treatment planning whether you're going to treat something yourself or whether you're going to refer it. If you are going to refer it, there's some important things I want to talk to you about. And that is, you can't just refer these type of cases to someone without some care and attention. And so if you're going to refer soft tissue surgeries to someone, particularly if you want to do restorative work afterwards, then you need to go and have a conversation, first of all, to make sure that the periodontist is comfortable doing soft tissue surgery. So periodontists are just like general dentists or endodontists. They sometimes have areas they like. So there are some periodontists who only like to do implants. There's some who only like to treat periodontal disease. There's some who like to do everything. And there are some periodontists now who specialise in failed implants done by other people. So there is a big variation. Or sometimes it's not even a periodontist. It might be, I have a few friends who are general dentists who take a lot of soft tissue referrals. And I have oral surgeons who take a lot of soft tissue referrals. But go and talk to them and tell them exactly what you want and check that they feel comfortable. There's two warning signs that if you hear these words, then maybe get a second opinion or talk to more people. If you hear the words, the soft tissue graft is probably not necessary, I believe the tissue is stable, so there's no need to do anything. In my experience, that means that either the specialist doesn't like doing soft tissue surgery or soft tissue grafting, they don't believe in it, or they're not very good at it, one of those three. So it's quite common when people say, I referred it off to a specialist and then they sent me a letter back saying it's not necessary and it didn't need to be done. That's a warning sign that they're just not comfortable doing it and you need to find someone else. The second one is you need to be very, very specific about what it is you're trying to achieve so that they can give you exactly what you want. So if you're going to do crowns afterwards, then tell them that you're going to do crowns afterwards. Or if you're doing something very particular, you may need to do the temporaries before they go off to the specialist. Now, even if you aren't planning to become a soft tissue surgeon, you should go and do some courses or get some information, because when you know nothing about a procedure, you are afraid of it. I have many friends who don't do orthodontics, they're surgeons or something like that. They don't do orthodontics and they find it incredibly mystical. I would say orthodontics is quite straightforward compared to most other types of dentistry. It's certainly the slowest type of dentistry, so you are much more likely to be able to fix an orthodontic issue because it takes months and months and months to go wrong, compared to an implant where you go through the lingual artery and kill the patient very, very quickly. And the reason they're afraid of orthodontics is because they don't know anything about it. So if you don't know anything about soft tissue grafting, even if you have no plans to do it, go and do a few courses. It's like if you're a periodontist and you know nothing about ortho, go and do one of those weekend courses or something on ortho, just so you have a little bit of an idea, okay? Otherwise, it's like it's a foreign language that's completely divorced from you. On the Academy, there's a whole bunch of free videos. There's free videos of showing the whole procedures, there's some lectures. There's 2 or 3 days of lecture material on soft tissue surgery. You can join the Academy for free. There'll be a link coming up in a moment. And it just so happens that this is soft tissue month for me. I have done about 4 soft tissue grafts in the last week and a half, and we've filmed all of them. So they're all currently going through editing and production, and they'll be rolling out on the Academy. You should be able to access most of those for free in the next month or so. Now, I would love some questions. So if you have some questions, please roll them through. Angela said, sutures, vertical sling sutures, and when to use this. Is it used when you need more tension for a subepithelial connective tissue graft, or is it used instead of other sling sutures? I don't use... vertical slings I do use. Vertical sling is a suture that I use to elevate the gingiva in the mid-facial of a tooth. So if I'm just elevating the tissue, normally I will do a normal sling. But if I am trying to really pull the tissue up right in the mid-facial, I will do a vertical sling. It's not tension that you're after, because if you're using a lot of tension, then the tissue will tend to fail. It is elevation. It's where you need a lot of elevation, you use a vertical sling. Sometimes I do both a traditional sling and a vertical sling. For those of you who aren't familiar with the vertical sling, I will do. We have some videos coming out very soon on very basic stuff like the different types of sutures that will be coming out in a few weeks. So how to do your sling, your apical sling, your vertical slings, your lateral suture, your horizontal mattress, all of these types of sutures. Although you need to remember with sutures that it's not about using a name. It's not about, I will use the lateral suture, I will use the sling. What you're thinking is, what does this suture do? When I do a certain type of suture, so sutures that are vertical mattress or horizontal mattress, because they take big bites of tissue, they're much less likely to pull through and open up than a simple interrupted. So you're thinking, okay, what does the suture do? Am I pulling more or less? Is it more important this wound stay closed? So for bone grafts, I tend to use a lot of vertical mattress because it's really, really super duper important that the wound doesn't open. With soft tissue grafts, it's a little bit different, it depends. The key thing with a suture is, one, how important is it not to pull through, and two, what direction do I want to pull, and three, what can I grab hold of to pull in that direction. So wherever you're trying to suture, think, first of all, what type of bite do you need? So do you need a mattress, or do you just need a regular type of suture or a sling? That's more to stop it pulling out of the tissue. The next thing you want to know is, which direction do I need to pull the tissue? Do I need to pull the tissue up? Do I need to pull the tissue sideways? Do I need to pull it over this way? Which way do you need to pull the tissue? When you know which way to pull, then you think, what can I grab hold of in that direction? And a sling is where you wrap it around a tooth or an implant and you pull against the implant. And they're great because you are never going to pull a suture through an implant. So it's got no chance, at least on one side, of pulling out. But quite often there's not a tooth there or there's not an implant there. So in those cases, we're going to take a bite of palate. So we're going to put the suture through the palate and pull against the tough tissue of the palate. So you can put it over, it seems a little bit rough the first time you do it, but if you want to pull that way and there's nothing over there except palate, then put the suture through the palate and pull against the palate. Adrian, what sutures do you use, when, and what suture materials do you use? Almost exclusively I have used polypropylene sutures for soft tissue surgery. In the past I used to use some gut sutures, but I have less faith in my patient's ability to heal now than I did. I have just trialled some Vilene sutures from Dyneck, which is an Australian suture company. I've tried them, they're quite a lot less expensive than some of the other sutures, and Vilene is really nice. It's not as soft as Teflon, but it's not as stiff and wiry as polypropylene. It's much less wiry than nylon. Now, all of these monofilaments work, so whether you use nylon or polypropylene or Vilene or all of the Dylock, all these particular materials are monofilaments and they essentially work the same. It's just how you enjoy using them. Some of them, like nylon, is very, very stiff and wiry and very prickly. William, what are the different grafting materials techniques? What's the pros and cons and applications? Well, there will be a video coming out with all of that stuff. We do have a whole bunch of soft tissue videos, but I've realised that we need some super duper basic ones just for the absolute basics, and that will be coming out in the next sort of 6 or 8 weeks. So be on the Academy and keep an eye on when that comes out. Clive says, is it okay to place a graft over composite material or some other restorative material surface where there is a big recession? And the answer is actually yes, you can. But there are some criteria. So I have had patients get attachment to amalgam, I've had them get attachment to composite resin, I've had them get attachment to GIC, and there is research showing that you can even get hemidesmosomal attachment to gold. So a lot of our theory about how deep restorative materials can go is actually based on having very poor margins. When you have something that's absolutely smooth and flush, then yes, you can get attachment to it. So I have done some grafts that go over composite resin coolers. If the tissue is thick, the core is absolutely seamless with the tooth and it's clean, then quite often you will get attachment to that as if you would. It's not going to be as good as if it's to dentine, but you will get that. There's a little bit more detail, and this particular course is really focused on why, and why to incorporate this more often. Lynn says, soft tissue graft, how do I choose between the materials on the market? Most of the materials you will use for soft tissue grafting come from the patient, so your first choice should always be the patient if you can. If you can't use the patient, the only material that has long-term follow-ups that I know of, and when I say long-term follow-ups I mean 20 years plus, is Elladerm. So it's an acellular dermal matrix. I mean, Elladerm's been used millions and millions, it's been used like 5 million times or something for dental cases, but it also gets used for hernias and breast cancer repairs and all sorts of things. So it's got a very, very long track record, but it has been used for a long time. Now, there are other grafting materials, soft tissue grafting materials on the market that have been around for a very short time, and I personally would not use any of them, because if you put a patient through a surgery and it doesn't work, the patient can be quite sad, and so can you. And the main reason we're using these is not for the patient's sake, it's actually for our sake, because we're afraid. We're afraid to harvest their tissue. So just remember you're a surgeon, you cause pain, get over it. Okay? You won't feel it. Emmanuel, with your very tough or novel cases posted, how do you decide on the treatment on the spot? I don't decide on the treatment on the spot, I decide on the treatment before the spot. So it's planned, and then I sit there and think about carefully how I will do the procedure on this particular patient. And then I visualise the treatment before I actually do the surgery, particularly if it's under sedation where I have a time limit, which, to be fair, I have stopped doing. Rajesh says, what's your opinion about grafting sockets after extractions? Well, I don't generally soft tissue graft sockets after extraction. I do often bone graft them, and I think it's a terrific idea, and my favourite way to do that is to put the graft in the socket and to put a Teflon membrane over the top. I get results with that. It's very, very consistent, and it's very, very easy, and I'm probably going to post a case later tonight of just how predictable and nice those results are. Mike says, I have some complication with connective tissue grafts. Any tips for less failure rate? Should the connective tissue graft be buried under the mucosa, or is partial exposure possible? Now, the problem with the word connective tissue graft is that all soft tissue grafts, all the autografts, are a connective tissue graft. The epithelium on the palate is about 50 microns thick. So if you do a free gingival graft, then it's a free gingival graft. A free gingival graft is completely exposed. The things that kill grafts, but a connective, we'll just stay on this for a moment. The moment you remove the epithelium, by definition, it becomes sub-epithelial. Because the epithelium is only about 50 microns. So anything, if you remove 50 microns from the surface of the graft, then it is sub-epithelial. Now, people tend to traditionally think that sub-epithelial is where you raise the big trapdoor, you harvest the tissue down to the bone, and you put the trapdoor back. But that is not true. That is we've got in the habit of this, but it's sub-epithelial. If you take a graft off the palate and you remove the epithelium, it's sub-epithelial. However, there is a big difference between the surface layers, which are very dense in keratin, and the deeper layers, which are less dense. The deeper layer close to the palate will tend to have some fat on the underside, and it is generally more beautiful. It's more difficult to get a good result because you have to do really massive grafts. So it takes, I think, more skill to get a good result. And in my experience, the resilience of this tissue is not as good. So it looks better, but in the long run, it is less resilient or less resistant to further recession. But if we go into why, if you do a connective tissue graft that's had the epithelium removed, try and cover it where possible. So really try and cover it. Even if the overlying tissue recedes after a week or so, its job at that first part is to provide nutrition to the graft, if nothing else. So if the tissue overlying recedes after a week or two, then by then the graft should have developed blood supply. But if we want to look at why do grafts fail, grafts fail because of, number one is movement. If there is any movement of the graft, so if you can get the lips of the patient and move it, and the graft moves, then there's a relatively good chance that the graft will either be poorer than you expect, so smaller, thinner, it will resorb, it will relapse, or it will just outright die. If it's a free gingival graft and it moves, it will die. Any part of a free gingival graft that moves, it will die. So that's number one. Number two is too thick. Obviously, when we're starting out doing grafts, we tend to make them too small, and so later on we think, I'm a big surgeon now, I will make a massive graft, and you'll take some big thick chunk off their palate because it bleeds like crazy for ages, and you spend quite a long time trying to stop the bleeding because it's pooling in the back of the patient's throat and you're worried about them getting sick. And whilst you're doing this, the graft is sitting on the bench dying, and then you put it in, and because it's so thick, you can't get nutrition into it. So if it's a free gingival graft and it's thicker than 2 millimeters, you won't be able to get the nutrition in through perfusion. So a free gingival graft gets nutrition from perfusion, so just the nutrients perfusing from the blood vessels in the bed or the periosteum into the graft. And if the graft is 3 millimeters thick, it's going to die. You can't perfuse that far. Even a connective tissue graft that's going to be placed underneath a flap, if it gets too thick, you can't get blood supply into it and it's too likely to die. Now the third, so there's two reasons. One, movement. Movement is a big killer. Number two, too thick. And number three, okay, I'm sorry, this one I don't really include in the list, but if you leave your graft sitting on the bench for too long, it's going to die, and then by the time you put it in, it's too late. So I always prepare the surgical bed. I harvest the graft, and I usually put the graft in, I just let the patient bleed a bit, and I just put the graft in and I suture it into position, and once I finish that, I go back and I deal with the palate, because I want the graft to be fresh as possible when it goes in. Even if I don't fully suture it, if I'm going to suture it down, like onto the surgical bed, just put a couple sutures in to sit it there, or slide it under the flap with 2 securing sutures either end, and then I'll go back and deal if there's a lot of bleeding. So there's the 4 reasons why they die. 1, you left it out on the bench and it just died. Number 2, it was too thick. Number 3, it moved. And number 4, if it's a free gingival graft, what happens when you create a surgical bed is that you can get bleeding and then you can get a clot form on the surgical bed. Now, if you get a clot on the surgical bed, clots are designed to stop blood flow. That is their purpose. If you get a clot on the surgical bed and then you place a graft over the top, there will be no blood supply because you have created the perfect barrier to any sort of blood or perfusion. That's the purpose of a blood clot. So if you have a blood clot on the surgical bed, the graft will die because there's no blood supply coming through. That's not such an issue if it's a subepithelial graft where you're pulling a flap over the top, but it's definitely an issue with free gingival grafts. Peter says, when restoring implant crowns, if you used a zirconia abutment, does a polished versus glazed surface affect the soft tissue response? Yes, it does. So if you polish zirconia and it's clean, soft tissue can attach to it with hemidesmosomal attachment. If you glaze the zirconia, which makes it look shinier, it won't attach so well. So polished zirconia is better than glazed zirconia. Vivek says, which antibiotic is recommended after soft tissue grafting and for how long? If I'm doing a graft with autogenous grafts, so I've taken tissue from the palate, I would never give antibiotics. You're taking a piece of living tissue, it's full of blood, you're taking it from here and you're moving it to there. It's not attached to the patient for about 7 seconds and then it goes in, or 2 minutes at the most. It's a superficial wound, there's nothing really particularly deep. If you've got any sort of tiny infection, I've never seen an infection with a soft tissue graft taken from the pellet, except where it necrosed, so where it died. If you make a soft tissue graft too thick, then it can die, and if it dies underneath the flap, it will look like an infection. The other thing you can get that looks like an infection is if you do a subepithelial connective tissue graft and you don't remove all the epithelium, and you pull the flap over the top of it, then the bit of epithelium that's left can actually form a cyst, an inclusion cyst. And then it will drain to the outside and it will tend to look like pus coming out, and you'll have to anaesthetise the patient later on when it's healed and remove the overlying tissue. So basically I don't use antibiotics. If I'm using Alloderm, then I generally will use I'll have to look it up. Okay, I can't remember the antibiotic. There's a particular antibiotic that's recommended to use, that's been used in all the protocols for a long time. And off the top of my head, I can't think of what it is. And the reason we're using that is because it's an artificial, well, it's not an artificial tissue, it's the collagen matrix from the skin of a dead person. Okay, but it is essentially a foreign body going into the patient, and so you have the potential for infection that you don't have with natural tissues. So in general, I don't use any soft tissue grafting antibiotics. Peter says, do you have any thoughts on the Chow pinhole technique? No, I don't have any thoughts. I haven't done the course. The before and after pictures I see look spectacular. However, I haven't seen really any long-term follow-ups by anyone except the person who created the procedure. So that makes me a little bit anxious. In my experience, now this is not related to the Chow technique because I haven't done it, but in my personal experience when I use collagen type materials as a grafting material, well, actually the last time I did that, I had relapse a year or so later, and then I ended up doing an Alloderm graft for free to repair it. So I haven't really, I have seen people I trust use cross-linked collagen membranes. So most of your membranes are either going to be cross-linked membranes or non-cross-linked. Non-cross-linked tend to allow blood vessels through a lot quicker, and it's good for bone grafts because you get blood vessels coming into the surface of the graft very early, which tends to give you the harder bone on the surface of your graft much earlier. But because we're not talking about bone, we're talking about soft tissue, a lot of these artificial materials really create a big scar. That's the purpose of them. It's not an ugly scar, it's actually scar tissue that creates the attachment. I have seen some people use cross-linked collagen membranes, but look, when I'm putting patients through a surgery, I want them to be fairly likely to get a good result that I know will last. And so my experience is that soft tissue from the palate is best by far. Alloderm is my next best, which I use when I've particularly got big cases or I've got a patient who is particularly adamant that I can't take anything on their palate, or where the case is not particularly severe but we want it to look really beautiful, because Alloderm, if it does one thing, it looks absolutely beautiful. It's probably the nicest looking, I would say it's the nicest looking of the grafts I use, because you never see that transition from the tissue that was there before and the tissue that's there now. Okay, unfortunately there was like a glitch before and we dropped out, and I don't think I have any more questions. So thank you very much for people who are joining. The recording will be up soon and you can watch it then. And if you have any more questions, please send them through to the Academy, and I can do a question and answer session or a video later to answer those questions. And we will definitely have some new videos coming out soon on basic suturing techniques, classifications of the different types of grafts and when to use them, and just some more basic soft tissue surgery stuff to complement some of the other things that we have that are more advanced. Thank you very much for joining us tonight.